would like you to take a small journey within yourself. Imagine a morning when you wake up to find that you are surrounded not by people you know, but by strange shapes, blurred colors, and voices seem to come from the other side of glass. Your own voice sounds distant and foreign. In this strange and scary world, you are at a loss to make sense of things. But other people seem to know exactly what is wrong. You are given a psychiatric label. You cannot be trusted to take care of yourself and must be removed from your home and put in a hospital. But hold on, you have a past. You have been associated with the mental disability field. You know the realities. Where would you rather go if you should one day need the services you now offer? If you are the parent, sibling, or spouse of such a person, where can you send them and feel confident that you have acted responsibly? The point of this solemn exercise is simply to get into the shoes of the service recipient so that we may design services that are more humane, inclusive, and meaningful. Some of you may have seen the recent film You, Me or Hum, in which the protagonist Ajay is a young psychiatrist whose wife Pia is diagnosed with a mental disability. The characteristic dilemma of the family in choosing either to care at home for such a member or to keep them at an institution is aptly highlighted. Trauma, guilt, self-doubt, and shame are commonplace. In this scenario, Family Psychoeducation, FPE, is a clinical practice with proven benefits, especially for the consumer and also for the family members. In the next few minutes, we will briefly see the benefits of incorporating family psychoeducation into standard practice. Some barriers to its widespread use will be assessed. An HELP model of care will be introduced that uses our knowledge of FPE and the recovery movement to help bridge the gap between research and practice. Let us spend a moment to look at the modern family. The modern what? What is a family today? The single adopted mother juggling her career with her maternal and social role. The post-retirement dad still working 2 jobs to pay for his kids' college, the 3 cars and the home mortgage. The double income no kids couple with spiraling ambitions because anything else feels like cheating on one's talents. Or is it the landless farmer's household who drinks water with red chilies so they won't feel hungry all day as they take a sick member to the nearest health 10 kilometers away? Truly, they are all family. Even that friend who is joyfully tending to his terminally sick friend when even his relatives won't. In the typical urban household today, women and men are fighting to rewrite their roles, even as moving to bigger cities and richer countries is creating a gaping hole in social supports. Expenses are mounting and economies are crashing. Expectations from self are at an all-time high, especially in an upcoming nation like India with much to prove. In such a scenario, people may naturally feel inadequate in caring for their relative with a mental disability. This creates the scene to introduce health practices that bolster the family as an important healing network and also fulfills the support needs of the family. Boring, huh? Sadly, some practitioners continue to see the family as a part of the problem. The legacy of older psychodynamic thought that blamed poor parenting and created the schizophrenogeneic mother still lingers on. This sword cuts both ways. Family members don't approach providers to get useful knowledge and skills because of guilt. Practitioners who can actually help them deal with their grief and loss become a source of stigma. And we, the providers, end up distancing those with the highest motivation to help our consumers. That is why the only responsible stance to take towards the family of a consumer is one of partnership and support. Slides 5 and 6 show the core characteristics of an effective family intervention. In spite of a variety of formats and adaptations, overall effective programs combine education, skills training and practical guidance. This is delivered with empathy, respect and support. Principles of recovery are followed, like strengths focus and being consumer and family driven. FPE FPE is one of the 6 established evidence-based practices in mental health. Yesterday we didn't get to hear about the other 5, so I'll enumerate them. Assertive community treatment, medication management, dual disorder management, illness management and recovery, also called wellness management, and supported employment are all now established evidence-based practices in psychiatric rehabilitation. An evidence-based practice, EBP, is a clinical practice for which scientific evidence of improvement in consumer outcome is consistent. As listed, different formats for FPE have been studied using randomized controlled trials and are all now an EBP. They have the core features just discussed, but differ in delivery and focus. Behavioral family management and family psychoeducation are single-family formats, while psychoeducational multifamily groups and relatives groups try to use group dynamics and economies of scale for similar benefits. Interventions last for at least 9 months and usually 1 to 2 years. Benefits of FPE are seen irrespective of expressed emotional status. Following the principles of psychosocial rehabilitation, at least a part B intervention is delivered in the community or home of the consumer. Another idea which has been tried successfully is peer or family level interventions, which leads to more inclusion and empowerment. The most significant result of randomized controlled trials with FPE is a startling reduction in relapse rates from 30 to 40% in usual practice to 15% per year. Besides this, consumers show improved health, relationships, community functioning, and satisfaction. FPE can also help reduce unemployment, behavioral disturbances, need for medicines, and hospitalization. Research on benefits to family members is somewhat limited, but shows improvements in knowledge, coping, confidence, and satisfaction with consumer behavior and with the services received. They also experience less stress and worry. From the research on benefits of FPE, we can see why clinicians and policymakers should make efforts to integrate it in practice. FPE is universally applicable, as seen from research in China, Scandinavia, UK and Spain besides USA. Also, the benefits are not limited to a diagnosis of schizophrenia, but are seen in a wide variety of mental illnesses. Thus, including FPE leads to a faster movement towards recovery goals, making the system more efficient. This can help to bring in widespread support and funding. Also, conducting such family groups can actually reduce overall costs of providing service. In a study in New York, it was found that for every dollar spent on FPE, there was a $34 saving during the second year due to reduced hospitalizations. This brings us to our next question. If FPE is such a great tool, why is it that even after 20 years of studying its benefits, it is still not common practice? The barriers to its use can be classified into attitudinal, systemic, practical, and knowledge-based. These may be at the level of the consumer or family, the clinician, or at the system level. For the family, as you can understand, there are issues of confidentiality, increased burden of care, hopelessness, stigma, and guilt. But a sensitive system can circumvent these by giving services at home, encouraging partial disclosure, being flexible, and involving the family in creating and evaluating the service. In today's tech world, FPE can also be offered through the internet to those preferring this format. This has the added benefit of anonymity and ease of access. In slides 13 and 14, we observe attitudinal, systemic and practical barriers holding us back. This includes high caseloads, costs of retraining, medical bias, restrictive policies, poor information, and a resistance to change. Clearly, creative approaches will be required to overcome some of these. The HELP model, to be discussed shortly, is one such attempt. A long-term cost-benefit analysis, more efficient advocacy efforts, incentivizing staff for using FPE, and including consumer-chosen goals will all be helpful.